Dr. Kyle Draheim, another in vivo scientist in product development, who will share her findings on an in vivo model to evaluate donor-dependent cytokine release in response to single agent or combination immune oncology therapeutics.
Hi, Jenny. Thank you so much for the introduction, and thank you to everybody who tuned in to listen. So today I'm going to talk to you about a model that we've developed to look at cytokine release syndrome or cytokine storm in response to single or combination immuno-oncology therapies. So one of the biggest reasons why it's very valuable to evaluate immunotoxicity is that antibody therapies are becoming more and more frequent to treat cancer as in addition to autoimmune diseases. Several years ago, a company by the name of TeGenero had developed a drug by the name of TGN-1412. It was a humanized monoclonal antibody against CD28, which is a molecule expressed on T cells. In the first in-person trials, once these patients were given TGN-1412, and these were healthy human volunteers, all of the people who were administered this drug had a life-threatening cytokine release storm. In all of the preclinical work that went into the development of this compound, showed absolutely no evidence of cytokine storm, and for this they had used both a rat model and a monkey model, and they had tested doses up to 500-fold higher than the doses that were ultimately given to these human volunteers. Another way that the company had tested their compound was to add the TGN-1412 to cell cultures of human PBMCs, and this also did not result in any cytokine release. After the trial where the patients had the life-threatening response, all of these key experiments were actually repeated by the British National Institute for Biological Standards and Control, and they actually confirmed the innocuous behavior of TGN-1412 in the preclinical studies. So this tells us that all of these assays that we're using to evaluate immuno-oncology drugs, whether it's rat or monkey or cultured PBMC assays, is not adequate to tell us if there's going to be a cytokine storm effect that was ultimately seen in the human volunteers. So we set out to try to develop a better model to detect cytokine release syndrome. And in order to do that, we knew a couple of things. We knew that it had to be fast, we knew that it had to be sensitive and reliable. It also had to be able to differentiate different antibodies that have the same target. So would one anti-CD28 molecule should behave differently than, say, a superagonist of CD28? We knew that this assay would need to be able to evaluate the effects on every person. Every person has their own immune system with their own genetic history, and so therefore we would expect variation from donor to donor. We also want this assay to be able to look at drug combinations, drug efficacy, and which cytokines were induced, and also hopefully be able to evaluate both drug toxicity and efficacy. So for this assay, we developed what we call an in vivo assessment of therapy-induced cytokine release syndrome, or CRS. Now, this assay depends on our NSG or NSG variant mice. We use PBMCs to humanize these. It is a short-term assay, which can use the adult PBMCs, where we use 4 to 5 mice per study group. We've tested a wide variety of compounds, including anti-CD3 antibody OKT3, an anti-CD28 monoclonal antibody, the TGN-1412, which is a superagonist of CD28, different checkpoint inhibitors, as well as bispecific antibodies. We then evaluate for cytokine release syndrome by bleeding the mice, collecting sera, and using a flow cytometry-based assay to determine specific levels of cytokine concentrations. So the first thing that we wanted to test is the engraftment of our PBMCs in our humanized mice. Here you can see we compared just 4 different donors. And you can see, in general, there's some trends that you see. We see that there are engraftment, which you can tell by the presence of CD45 in the mice. Engraftment increases with time, with the earlier time points having anywhere between 10 and 20% engraftment, and later time points being much higher than that. We also see that most of the immune cells in the PBMC humanized mice are T cells. Another thing that you can see among all 4 of these donors is that the NK cells are seen at the earlier time point but diminish at the later time points. However, we do see some donor-to-donor dependent variations. For example, you can see changes in the B cell or monocyte engraftments, whereas for some, the B cell engraftment stays comparable throughout the 2 time points, some it increases, and other donors where you have better engraftments of NK cells. So it is important. Oh, I'm sorry. We then wanted to look at the response of the different compounds and their impact on different cytokines. It is important to look at several cytokines because not all compounds affect the cytokines equally. For example, when you look at the anti-CD28, you can see that it causes anti-CD28, which is green. You can see that it causes the release of interferon gamma much more, and IL-10 much more than ATG. However, when you're looking at TNF-alpha, ATG induces much higher release of TNF compared to anti-CD28. So after looking at the normal compounds, we felt it was very important to also look at bispecific antibodies, and this is piggybacking on some of the data that Lily had presented in the talk earlier to this. So early in 2019, there was a lead biotech company that had disclosed 2 deaths from its bispecific antibody. It drastically impacted their bispecific antibody program along with their shares, and the chief scientific officer addressed the fatalities of the program. The compound that was being tested was a bispecific antibody against CD20, and their preclinical studies or their preclinical test didn't show an impact, but however, when they actually put it in the patients, with patients that had lymphoma, they saw a much increased levels of toxicity. The chief scientific officer, when discussing the issue, said that they believed that the enhanced cytokine release syndrome was associated with the tumor levels, and that this was probably the cause of the 2 deaths. So it's important to not just look at the cytokines that are released from one donor to the next in response to different drugs, but to also look at it in subjects that bear the tumors. So to test this, we decided to look at an EGFR BiTE using mice that had been engrafted with MDA MB231 tumor cells in our PBMC humanized mice. And in this, we either engrafted them with the tumor cells or we chose not to engraft them. Here you can see that in the group that did not have the MDA231 cells injected, that we saw no cytokine release without a tumor being present. However, when there were tumor cells present, you see a significant induction of interferon gamma and TNF across all three donors that we had looked at. Once again, you can also see the difference between donors when you looked at the cytokines that are released. We also looked at other cytokines, IL-10 and IL-6, again showing the same general trend. But again, you can see donor-to-donor variability. For example, for donor B, you can tell that IL-10 is released. It's only slightly lower than the BITE and KEYTRUDA only groups when compared to the combination group. However, when you look at the IL-6, this impact appears to be additive. However, for donor C, it's the complete opposite, whereas the IL-6 appears to only be slightly higher in the combination group, whereas for the IL-10, the impact seems to be closer to additive. And again, you see this trend continue with two other cytokines, IL-4 and IL-2. So we then decided that we needed to further delve into the donor variation. And donor variability is one of the things that's going to be a constant theme throughout this talk. And every time we turned around, and every assay, and every cytokine that we used, and every drug that we used, you could see that sometimes there would be difference between donors, and sometimes there wouldn't. So for this particular assay, we decided to use a BCMA, BITE, and using Raji cells, which express high levels of BCMA. So the approach was similar to before. We would engraft the mice with the PBMCs. We would then inject the Raji cells, check for humanized cell engraftment, and then dose and bleed to evaluate cytokines. And once again, this assay can distinguish between PBMC donors. You can see that donor A actually has a relatively low background with decent IL-6 induction after BITE treatment. Donor B has a fairly low background with not as high of a induction after treatments, whereas donor C has a much higher basal level of cytokines released and is also induced with the BITE and the combination groups. So another important factor that you need to keep in mind when developing this assay was that the time points that are used to evaluate the cytokine levels in the serum. So this is best shown using TNF-alpha. Here you can see that TNF-alpha levels in the first time points, the combination groups appear to have comparable levels to the BITE-only groups for both donors B and C. However, at the later time point, you can see that donor C still has higher levels of TNF-alpha in its combination group, but this has receded in the combination group for donor B. This contrasts with the rituximab-induced TNF, which is higher at the second time point for all donors, and the anti-CD28 groups, which have similar TNF-alpha levels at both time points. So in order to more fully evaluate the timing for each cytokine release, we set up another experiment, this time using a CD19 BITE, still using the Raji tumor cells in our PBMC humanized mice. Similar as before, we engrafted the PBMCs, we injected the tumor cells, checked for engraftment levels, dosed the mice, bled for toxicity. The difference is with this, because the Raji cells are tagged with luciferase, we actually also measured the mice for tumor burden at the very end. So at the beginning, you can tell that for interferon gamma, you can see comparable levels of release at both time points. However, as we had seen before, at TNF, that came higher at the earlier time points when compared to the later time points. This variability continued when looking at IL-10, IL-6, and IL-2. IL-10 seemed to have comparable levels of release for the two different time points, but IL-6 and IL-2 both showed more a higher concentration at the earlier time points when compared to the later. We wanted to see if the cytokine release was comparable or was in some way indicative of tumor response. So just as a reminder, we have TNF here where you can see some induction at anti-CD28, not much with rituximab. The BITE showed an induction of TNF alpha. The combination group showed even higher. And then we show a similar pattern, albeit at different levels at the second time point. When you're looking at the xenogen or the total flux released for the luciferase signal in these mice, you can tell that before the dosing, they all had fairly high levels of luciferase signal, but shortly after the dose, that the rituximab group had a definitive drop along with the BITE and the rituximab combination group. This does not correlate with the cytokine release. And as we try to work towards personalized medicine, where the goal being that we could take a person's own PBMCs and some of their own tumor and graft them both into mice and test compounds, this just shows that you cannot use cytokine, or you don't need a cytokine storm in order to have efficacy for the compounds. That is not just the price to pay for an effective drug compound. That you really need to evaluate all the different aspects before pursuing. Another way that we evaluate our cytokine release syndrome is that we have a CRS score in mice where we take upon different physical measures that include weight loss, that include activity, that include hair loss or ruffled skin or hunched behavior. In our assay thus far, in all of the groups at the early time points, all of the mice appear to be very healthy, but shortly after dosing, the anti-CD28 in the BITE groups started having higher CRS scores, which indicate toxicity. However, as we continued to progress and monitor the mice after dosing, you could see that even the PBS group started to creep up and started to have a higher CRS score. When looking at the mean body weights of these groups, also as a readout for how healthy the mice are, you can see that while one group, the anti-CD28 group, was clearly diminishing, the rest were variable, but slowly trending down when it came to their body weight. So this is indicative of xenogenic GVHD. This is mediated by the human PBMCs. So in this, when you take your mouse and engraft the human PBMCs, after a while, the human PBMCs are going to develop the immune cells that will slowly attack the mouse, as it will recognize the mouse cells as a foreign agent. This can be indicative by hair loss, hunched posture, weight loss, or even death. Here we have an example of a healthy mouse. This is a mouse that has a CRS score of 0 versus a sick mouse with a higher CRS score. So in order to combat this, in order to reduce the amount of xenographic GVHD in our humanized mice, we turned to the literature and found that, as any immunologist can tell you, that as the majority of the human cells within an NSG mice are T cells, if we introduce that in mice that are lacking MHCs, then we will be able to reduce the susceptibility to xeno-GVHD. Fortunately for us, these mice had been made, and so when we cross it onto our NSG background, you can see that after engrafting PBMCs, it's the same donor, in either NSG, MHC class 1, or class 2 null mice, once you get to a certain point, then NSG mice slowly start to die off due to xeno-GVHD, whereas the class 1 and 2 knockouts are much longer lived, and but after a while, even they slowly start to become susceptible. So the model that we chose to then take was actually an MHC class 1, class 2 double knockout on the NSG background. So to test the cytokines released, to make certain that that was not impacted, this is not in tumor-bearing mice. Again, when comparing the NSG versus the class 1, 2 double knockout mice, you can see that they have comparable levels to human immune cell engraftments in all the cell types looked at. However, when you look at the body weights, and this is indicative of the xenographic GVHD, you can tell that they have that while the NSG mice started dying less than 2 weeks after PBMC injection, the class 1, 2 double knockout mice carried on for quite a long time. Now, this allows a much greater window of evaluating of humanized mice that can be used to evaluate tumor-bearing immuno-oncology therapies and the cytokine release syndrome that can be induced by these therapies. When testing whether or not a same donor would have the same cytokine release, we had looked at checkpoint inhibitors and then anti-CD3 antibody OKT3, and found that between the double knockout and the NSG, for all of the cytokines tested, had practically identical levels of cytokines that were released. So with that in mind, we developed our next platform in which we take our tumor cells or PBS for no tumor controls. We evaluate for tumor burden, then we engraft for PBMCs in these double knockout mice. We can check for engraftment levels, continue to measure the tumor burden, dose the mice, bleed for toxicity, and then measure tumor burdens. And this is a way that would allow us to look at both drug toxicity as well as efficacy using the exact same model. So here you can see when we're looking at the cytokine release or the toxicity at the 2 time points without the tumor, as we'd expected. Without the tumor, you do not see any release of cytokines in any of the cytokines that we tested in response to one of the bites. However, in the presence of tumors, you can see an induction. Again, depending on the time point, you can see for interferon gamma at an earlier time point, we see some release of interferon gamma, but a much more significant at the second time point. And again, with TNF alpha, this has its own profile as well. Once again, you need the tumor in order to have release of TNF alpha, but it is clearly present at both the time points that we had tested. And this pattern continues for all of the other cytokines, IL-10, IL-6, IL-2, along with the others that we have not shown. So we then, So then again, now that we could see that yes, this donor can tell us about tumor-dependent cytokine release syndrome in response to the drug, but what does it do insofar as the tumor burden? So just a reminder, this is just of the tumor-bearing mice at the critical time points. We can see a release when you have a combination of both the EGFR and the anti-PD-1 therapies. It's interesting here because for this particular donor, at certain time points, they all appear to be either additive or, in the case of TNF and IL-2, very synergistic. Whereas if you look at interferon gamma and IL-10, it was, for interferon gamma, it was no different, the combination group was no different than the BiTE alone, or for IL-10, it was a little less than additive. However, when we compared that to the drug efficacy, and again, this is just to remind you what we had seen for TNF, you can see that the bite practically killed our luciferase signal. Here after treatment, even after the bite alone, we have next to no tumor cells left. Whereas if you look at the change in the TNF alpha that is released, the bite alone has a much lower level of the combination group. So this is an assay that might be able to be used to determine the costs and benefits of combination groups. Again, when we're looking at our CRS score, you could see that shortly after, the two bite-containing groups did have a higher CRS score, and they stayed high. But after time, they actually started to come down. So these mice were recovering. They were getting healthier, whereas the group that was treated with the anti-CD28 was just slowly getting worse and worse and worse. For the PBS and Keytruda groups, they've never shown a cytokine release, so they've always stayed at the baseline. But this shows that we very definitively do not have the xenographic GVHD, as these mice are now recovering, showing the benefit of these class 1, class 2 double knockout mice. Again, when you're looking at the body weight, you can see that our anti-CD28 just starts going down. They're clearly suffering from toxicity in response to the CD28, and they cannot recover. Whereas the two bite groups, while they are impacted at the beginning, they do start to recover after a while, and this is probably in a large part due to recovery from the tumor. Because when you look at the luciferase signal in the lungs, this is the total flux on the y-axis. While you see that this is all after dosing, at the beginning the mice are dosed, it still continues to rise at short term, but long term the bite groups drop, whereas the Keytruda and the PBS groups continue to grow, and then you see a huge spike in the anti-CD28 groups, and this is probably due to the fact that the PBMCs are depleted at that point. And this is just the individual mice so that you can see the spread of the different compounds. But in general, we actually have a very close grouping of this data. And this is an example of the xenogen data that we see. Again, at the earlier time points, you see comparable levels. This is actually pre-dose. Shortly after dosing, you don't see much impact, except maybe a little bit in the bite-treated groups, whereas further out, you could see that the anti-CD28 have a very high signal. The Keytruda and the PBS have a more moderate signal, whereas in the two bite-treated groups, there's very little tumor signal left. So in conclusion, in all of the therapy groups, each of the cytokines that we had tested, which included interferon gamma, IL-2, 6, 10, and TNF-alpha, were upregulated in the time after drug treatment. We were able to see donor-to-donor variability, and it was evident in both response to single agents as well as drug combinations. In general, our cytokine release correlated with the dose that we gave to the mice, along with the PBMC engraftment levels and the tumor burden, but that was only held true within the same donor. You couldn't predict that a donor that did not engraft as well might still respond more strongly than another donor. We can show different both additive and synergistic cytokine released in combination treated groups and compare these in terms of their efficacy versus single agents. I want to highlight that this particular protocol was able to determine a cytokine release syndrome that was missed in the in vitro testing models for other drugs up to this point. So in conclusion, we have developed a very sensitive translational humanized mouse model that can be used for preclinical assessment of both efficacy and cytokine release adverse events in response to immuno-oncology therapies, both as single agents and in combination. This is the end of my talk, and I would like to thank all the members on my team for their contributions towards this work.